Thank you very much for having me today, Neil. My name is Philip. I'm a professor of oncology at Wayne State University and also Henry Ford Cancer Institute in Detroit. My area of clinical practice and research is in gastrointestinal cancers and neuroendocrine tumors. So, what I'd like to do is go over some of the presentations from a recent ASCO we had this year and try to focus on things that will have an impact in terms of the patient care and so practical aspects of the presentations and how it applies to our day-to-day practice. I'm going to start off with a presentation which was part of the colorectal sessions, which was looking at the ctDNA dynamics as an early predictor of recurrence in resected colorectal cancer. And this was an update from the Galaxy study, which is within the Circulate Japan project or trial. And as we all know, ctDNA is becoming a rapidly increasing important assay that we use or a test we employ in terms of managing patients with different cancers. But there's more data nowadays we have in colorectal cancer, so you might as well just go over this study. This included over 2,000 patients, and these were stage 2 to 4 resected. Obviously, stage 4 resected, but stage 2 and 3. And in this study, which was presented before, ctDNA has been shown to be prognostic in terms of its value, and in fact, probably the most prognostic thing we have in terms of evaluating patients in terms of recurrence, stage 2 and 3. And worst is in patients who have ctDNA positivity and also BRAF mutation. The interesting thing is that the ctDNA positivity, when it was followed by doing scans, there was a lead time of approximately 5 months before the radiology was seen or positive. So at this point in time, we really believe in that the ctDNA has a major prognostic value, and as such, and I can tell you that from the study that was published in Nature Medicine in 2023, the hazard ratio for recurrence was 10. So it's really very powerful in terms of predicting recurrence. The question becomes, when you get the recurrence, what do you do? And or if you see a positive result, what do you do? And that's something which is currently being actively investigated in terms of the positivity and the negativity in 2 trials, the Vega trial and Altair trial being done in Japan. So certainly an area that is evolving, and we have to keep a close eye on what's happening, because it will soon, and I will say soon, impact the way we manage patients with colorectal cancer. There was another study which was more like a retrospective kind of analysis of the Intercept program. I call it retrospective. It wasn't like done prospective as the previous study I really mentioned. And this was the Intercept program from the MD Anderson. And this was basically the ctDNA surveillance looking for minimal residual disease in patients who have resected colorectal cancer. This was over 1,000 patients, median age 58. And this was again stages 1 to 4 following a curative therapy. And they used the informed MRD assay. So informed meaning that the patients had to have a baseline, or prior to doing the test, they had to have the signature established, and then you can then follow up every 3 months by doing the plasma ctDNA and looking into a recurrence of the tumor or MRD. And you can see here that the most important point about this is that when they did this, half of the patients had radiological evidence of active disease or metastatic disease, obviously in this case, and half of them did not. So the ones who did not have metastatic disease on radiology, these are the ones you would call true minimal residual disease, which hasn't been shown yet on a scan. And again, they looked at the level of the MRD or the level of the ctDNA in the plasma, and surely patients who have low levels are unlikely to be showing a positive scan, whereas the ones who have a higher level are likely to be showing that. And that's really something which we would expect based on this. So this is something which is really important for us to really understand as we're going forward in this ctDNA use.
So if I could ask, I just kind of thought of something I hadn't thought of before. We, of course, have talked a lot about Signatera and ctDNA, but I'm curious, do any of these studies, do they also look at conventional tumor markers like CEA to see how that correlates?
They do, but I don't think the data is presented, or I haven't seen a good analysis comparing one to the other. Or at least I failed to see any data to come up with more robust, like a statistical or even descriptive statistics to look at the relationship between the two.
Yeah, that was what I was just thinking, because it might be interesting. I don't know if you have enough experience clinically that you can say, like, if you also have a CEA up or down, is that like a cofactor?
I would say it's probably a cofactor, but you have to understand that the CA sometimes is negative and patients have recurrence, and that's really
Sure.
the real value of the
Right.
ctDNA, is to have something there, um, and um, and the value of the CEA also is can also sometimes fluctuate based on a number of other reasons, including inflammatory condition of some sort. So the ctDNA is presumed to be the more accurate, especially when you use an informed assay like the test that was used in this clinical trial. The other thing which is important is that we have to also find a kind of a management plan for patients who have ctDNA positivity, because identifying them is not enough, especially when we don't have a scan that's positive. And based on the study here, we're getting this approximate 50% of split between finding something on a scan or we don't. Obviously, with time, you will find something on the scan as the levels go up. But when we see the positivity for the first time, especially if we can confirm the positivity with maybe even a confirmatory test, which doesn't appear to be that these studies have incorporated that in terms of informing us whether we need to do that or not. Those patients at this time, we don't know what to do with them. One way of dealing with those patients is to put them on clinical trials. There are some clinical trials that are ongoing looking at positive or MRD present colorectal cancer. And then becomes the issue of, do we really discuss with the patient starting chemotherapy at this point in time or not? And I don't think anyone has a good handle on this. The question is, if they have metastatic disease, if that's what the assumption is, which it is, does treating a patient 5 months earlier or 6 months earlier make a difference in their ultimate outcome? But on the other hand, diagnosing the recurrence earlier may also allow a patient to have more definitive curative strategies, such as resection of metastases and all that. But I think as we go along, this is not going to be the only thing. It's going to be surrounded by other research that's really going to make the field more interesting and more hopefully informative. But the most important thing is more impactful on patient management.
Yeah, it's kind of interesting. It's sort of an analogous situation in prostate cancer, believe it or not. They have new assay, the PSMA scanning,
Yeah.
and they're picking up people with Mets that, they never could pick up before. And the interesting thing is they're very pro doing it, really for the reason you just said, which is you could pick it up earlier, a better chance it's going to be a ligo where you can, treat
Yes.
locally.
Yeah, and again, I think you asked me about the CEA. The CEA, we know that it hasn't been. Uh, I mean, it has been helpful, but maybe we can do much better by doing the ctDNA testing. So these are the conclusions, which are pretty much similar. One thing I have to really point out is the studies are doing it every 3 months, and I think that's what people have been used to doing it. So the paradigm trial, this is a study that has that has been presented before. But here the focus is on, again, on the efficacy of anti-EGFR strategy here using panitumumab in patients who have left-sided colon cancer, who have microsatellite stability or MSI low, but also their RAS BRAF wild type. And in this phase 3 trial, that was a comparison between panitumumab or bevacizumab added to modified FOLFOX6. There's clear benefit in patients who have left-sided colon tumors with a hazard ratio of 0.79, of median overall survival of 40.6 to 34.8 months. Whereas in the right-sided tumors, although numerically it's superior, but the hazard ratio is close to 1 is 0.94, and the p-value is not significant. Also, looking at resection rates, and especially the R0 resection rates, were significantly higher in patients who had the panitumumab in the left-sided colon tumors. And at the bottom of the slide, I have a table here that I'm showing the distribution of some of these biomarkers, just to remind the people who are watching this, is that the BRAF mutations, as you know, are more prevalent in patients who have right-sided tumors, and the same thing applies to the MSI high. So this study concluded that this is additional data, biomarker-driven data, molecular-driven data, to really really establish a role for the panitumumab added to chemotherapy in patients who have left-sided colon cancer. Again, here we're talking about metastatic disease, obviously not in an earlier stage disease. And so I think this is something which we have to keep in mind when we're starting people on frontline therapy. But there's a caveat here also, because patients who have RAS wild type, BRAF wild type, we have to really look at these patients earlier on, probably when we're looking into starting patients on treatment. But that's something, a point for discussion later on. Then we move on to HER2. So HER2 positivity has been very well known to us for gastric, and before that, obviously for breast cancer. But certainly, when it comes to colon cancer, colorectal cancer, we have been getting into it. And one of the reasons is that the HER2 positivity is much lower than what we see in breast, and lower than what we see in gastric. It's 3 to 5% of the patients. And certainly, if you don't, you have to do the test so that you know the patient has it or not. So we're all familiar with the Mountaineer study, which was a single-arm trial, which led to the approval of tucatinib plus trastuzumab as a treatment in patients with second-line or beyond who are HER2 positive. And in colorectal cancer, this was a study that showed a response rate of 38.1% with a very interesting PFS of 8.2 months and a median OS of 24 months. And you have to really compare these numbers to what you see in the second line when you're using other modalities of treatment. For example, chemotherapy in the second, third line. For example, if you were to use anti-EGFR treatment, all of us remember the old Bond trial, which was cetuximab and irinotecan in the second line. And the way they really selected the patients for HER2 positivity, it could be immunohistochemistry and FISH on tissue samples, or it could be tissue next generation sequencing, or it could be ctDNA, again subjected to next generation sequencing. And here they showed that there was a high percentage of agreement across the different platforms used. And however, the ctDNA may miss the HER2 amplification, and therefore one has to be aware of this. And you may want to do a tissue testing in patients who you suspect or you think that they have HER2, and then you have to prove that. And when they looked at the different platforms, positivity predicted for response in this situation. So just to go a bit more into another anti-HER2 strategy in colon cancer, colorectal cancer, advanced colorectal cancer, is Destiny CRC02. This was now a randomized phase 2 study of trastuzumab and deruxtecan in HER2 overexpressing or amplified metastatic CRC. These are patients, like, this is probably more or less what we're using nowadays, IHC 3+ or IHC 2+ confirmed by a in situ hybridization positivity. Patients allowed prior chemotherapy, including HER2 targeting treatment. Median, they had 3 lines or more, and most of the patients had IHC 3 plus. And this is, I find this interesting that RAS wild type was seen in over 80% of the patients. Interesting thing here is, for me, I always believe that RAS and HER2 are kind of one or the other, because these are oncogenes and only one of them can drive the tumor cell. But I guess there might be some possibility there of some patients will be also RAS mutated. I can't understand the exact biology there, but based on this study, there were some patients. But I don't know if the study at this point in time gave us a good indication of what happened to the patients who had RAS mutant plus HER2 overexpression. As you would expect, most patients had left-sided colon cancer. So one thing to really, in the earlier slides, I had the BRAF being more common in right-sided colons, MSI high more in right-sided, but here the left-sided colon tumors have more of the HER2 positivity, which is also important because when you have left-sided colon tumors, in my paradigm study presentation, I mentioned that panitumumab in that study showed that it works in the left side better than bevacizumab. But the question becomes, if you have someone left-sided tumors who are RAS wild type, but they also happen to be HER2 positive, are you really going to do? Are you going to think that the HER2 positive RAS wild type will be as responsive to panitumumab, or you have to think of something different in those patients? But that's something for discussion. This is just showing the outcome of the study, and you can see that, and these are the numbers for response rate. And they also, if I just go back to, so they had also something which I should have mentioned earlier. They also looked at 2 dose levels, 5.4 milligram per kilogram given every 3 weeks, and also 6.4 milligram per kilogram given 3 weeks. And in this trial, you can see these are the numbers here in terms of the response rate. And we're seeing response rates in the 30s. And again, this is something which the numbers are a bit small, but certainly we're seeing a significant number of patients who are responding. And also, if you look at the disease control rate, these are patients who are having some good disease control rate, given the fact that we also think that those patients can be worse prognosis. And if you look at the depth of the responses, we see a fair number of patients having responses, but also few will qualify for a partial response. So certainly an active treatment in patients who have HER2 positive disease. And again, remember, these were patients who were relatively heavily treated, pre-treated, and some of them probably had anti-HER2 treatment because that's allowed. Now, again, there's some distinction when it comes to response rate. If you look at the patients who have the 5.4 milligram per kg, which the study concluded that that's the dose that they really want to be continuing with, and that's the dose which is recommended in this setting. The IHC 3 plus patients had a better response than patients who had IHC 2 plus confirmed by the ISH. So that's something interesting for us. I mean, for IHC 2 plus patients, even if they're confirmed by the in situ hybridization, we're not seeing like as robust response rate. In fact, nowhere near the 3 plus. Now, again, one of the side effects of this treatment is, as we well know from previous studies, will be the interstitial lung disease and pneumonitis. And you can see that it was a bit higher in patients who had the 6.4. But there were no patients who had greater than equal to or greater than 3 in patients who had the 5.4 milligram per kg. And there was a single patient who unfortunately died of the ILD in the higher dose regimen. So at this point in time, there is activity at both those levels, but the one which is really continuing with, or the one which would be recommended is the 5.4 milligram per kg. And the interesting thing is that anti-tumor activity was seen irrespective of the RAS status, which is something which I was questioning before, and also in respect of whether they had prior HER2 therapy. So another option for patients um, who have HER2 positivity in their disease, colorectal cancer, metastatic colorectal cancer. And again, this was done in patients who had more than 3 or more lines of treatment. Okay, so next we move on to trifluridine, tipiracil, an oral agent, and which we're very much familiar with. We've been using it for a number of years now. This was a study in combination with bevacizumab. This is an analysis of the phase 3 trial, which is already published, actually. Just to remind you, this was a large international trial, showed the superiority of the combination with bevacizumab versus single agent alone. It met its primary endpoint of PFS superiority. And this was post-hoc analysis of patients who maintained their ECOG 0 or 1 and what happened to them, and maintaining the good performance status or maintaining their physical performance really allowed them to continue more because they still did better than the patients who got the single agent, and this allowed them to get more treatment. So I think this is just a proof for that. Okay, so we need more drugs. With colon cancer, we've done well in getting to the third line. Now we need drugs, fourth line, fifth line, and then there's another drug here which went through a phase 3 trial. It's an oral agent, fruquintinib, versus placebo. These were patients who had refractory metastatic colorectal cancer. This was published in Lancet 2023. This was over 900 patient study. And here this analysis is looking at what they received prior to getting the fruquintinib and also how many lines of therapy they received before they got to that point. And the bottom line from this trial is that fruquintinib was superior to the placebo in both PFS and OS, irrespective of the kind of the prior therapy they received or the number of lines of therapy. Just to refresh your memory, this is a drug, oral drug, which is a potent VEGFR1 to 3 antagonist. And again, it's just another drug that adds to our armamentarium, allowing frequent subsequent lines of therapy. And just to remind people, the side effects include hypertension, asthenia, and hand-foot syndrome, which is something to be expected from this class of drugs that we have. Okay, so that finishes my colon cancer. Now I move on into gastroesophageal cancer. And one of the exciting things about this disease is that, again, we're adding more targets and more drugs. And Claudin 18.2 was investigated, as you know, in 2 studies, 2 large trials, Spotlight and GLOW. These were global trials. And Claudin 18.2, as you may remember, is a cell junction protein and increases apoptosis and also sensitizes tumor cells to cytotoxic therapy. In both studies, there was benefit in adding zolbetuximab, which is the anti-Claudin 18.2 monoclonal antibody. And there was approximately or about a 2-month improvement in both PFS and OS, and it was kind of similar in both trials, just confirming that there's activity there. And here there was this study, looking at the expression of Claudin 18.2, because always the question is, well, we have a target, but is it going to be like one of those 2% targets, or is it going to be one of the better targets that we can be more comfortable in putting patients on, or even thinking about it, because there are more prevalence of this? And indeed it is. Positivity is 39.1% globally, and within the United States is very much similar to the global. And there is a bit more of it maybe in gastric cancer, but not much more of it. In terms of the association with immune biomarkers, the PD-L1, CPS score of 5 or more, 17.4% of the patients had both. And when they looked at across different clinical and histological characteristics of gastric or GE junction tumors, the expression was pretty much similar. So In conclusion, this is a high prevalence biomarker in gastric and EG junction cancers, and it's going to be very interesting, really, to have this as another option for our treatment. The side effects would be nausea, vomiting, and also reduced appetite. It adds to the chemotherapy. And just to remind you, these two studies were done in patients who had HER2 negative disease. We move on now to hepatobiliary cancer. Now, hepatobiliary cancer is interesting because for a long time we tried to find a solution for the recurrences that happen after whether you do resection part of the tumor at the liver or you do ablation. And a number of strategies were tried, but this is the first really positive treatment that we can give in the adjuvant setting, which is the combination of atezo and bevacizumab in a study that was that's already known to many of you, the AMBREV 50. In this trial, there was a benefit of using this combination after resection, and in fact, when it was presented or people were made aware of it, the primary endpoint, which is relapse-free survival, was not really reached at that point in time. So the treatment is given for 1 year, and this is in patients who are identified as being high risk, like large tumor size or multiple lesions in the liver, lymphovascular invasion, or people with poorly differentiated or high-grade tumors. Here, it just showing you that that in patients who provided or filled the questionnaires or provided information on the reported outcomes, really it was maintained, and it's comparable with both arms of the trial. So it's not really you're not really disadvantaging the patients. In fact, they're maintaining their quality of life despite this treatment and the potential side effects that come from this treatment. So the other study that was kind of not updated, but we heard more about what's happening in terms of patients who have immune-related adverse events. Does it really correlate, or does it have an impact on patients who receive tremelimumab plus durvalumab in patients with unresectable HCC? This was the Himalaya study, which was first presented in ASCO GI last year, 2022. And as you know, this was a study that had 3 arms. The control arm was sorafenib, and they had STRIDE, which is tremelimumab and durvalumab, and they had also a single arm, which was durvalumab. So this study showed the benefit of using the combination treatment, and in terms of it showed that there was superiority when compared to sorafenib in terms of overall survival. Now, if you look at the occurrence of or frequency of the immune-related adverse events, you see that they happened early in the course of the treatment, within the first 3 months. And when they looked at the comparison between those patients who had the immune-related reactions or side effects compared to those who did not, I would say numerically there was a bit of improvement, although probably it wasn't significant, and I don't know if this was really powered enough to do that. But certainly there is some increase. But overall, patients who have the reaction, they also do better than the sorafenib. Again, so most of the side effects, immune-related side happened within the first 3 months of the treatment. They were low grade and manageable. And again, the long-term benefit or the efficacy was irrespective of the occurrence of these side effects. All right, so we know immunotherapy works in this disease in a proportion of the patients. This is another drug, which is tislelizumab, which is a drug that was tested in a phase 3 trial, global rationale 301. And this was just analysis looking at the outcome in patients who were from Europe and North America. So you know that there is a bit of a difference in the epidemiology in terms of the causation or the etiology of this disease. And the question is always, do the geographical variations leading to different etiologies make a difference in how we respond to drugs, including immunotherapy. The bottom line is that it did not show. It showed the non-inferiority, which was the primary testing for this disease, but it and it continued to show that in patients who from the EU and North America. So basically, it's non-inferior as we've seen it before, and continues to be like that in this subpopulation when compared to sorafenib. And the question is, does this? How does this drug fit into what we're doing and what we're doing now? That's a question, and it's also a topic for discussion, I guess. Now, moving forward to biliary cancer here and looking at Keynote 966. As you know, this study was again a phase 3 trial adding placebo or pembrolizumab to patients with who are getting gemcitabine and cisplatin, which is the standard of care in those situations. This the cytotoxic component, and again here they looked at quality of life using the ORTC QLQ-C30 analysis, and you see that the quality of life is maintained in those patients whether they receive the placebo or the combination with the pembrolizumab, not adding much in terms of their well-being. In fact, they do very well with the combination. Okay, back to HER2 now. Again, in biliary cancers, this study looking at it's a phase 2 trial. It was a phase 2 study looking at tucatinib and trastuzumab in patients who are HER2 positive solid tumors, and here there is some focus on we can talk about biliary cancer. And here you see the response rate, which was 46.7%, with a very decent disease control rate, and a median duration of response of 6 months, and a median PFS of 5.5, and a median OS of 15.5 months. And most patients tolerated well. Only less than 5% had to really discontinue the treatment. This was a study in multiple cohorts, and I'm showing it on the slide here so that you are aware of it. And the primary endpoint being overall response rate, the ORR, and you have it here as close to 50%. So the conclusion here is well tolerated, and these patients also included patients who have been previously treated with other lines of therapy, as we see in many of these studies, the way they're designed. And therefore, this non-chemotherapy combination of the two drugs will be a very reasonable thing as a treatment option in the future, once we have more information and more and also approval for this. Now, again, it's very interesting that the trastuzumab tucatinib combination is really looking at very strong vertical inhibition of the HER2 signaling pathway, because you're hitting the extracellular domain of the receptor with an antibody, and then you're hitting the intracellular domain or the tyrosine kinase or the business end of the receptor with another drug. So you're getting more effective combination treatment. Certainly, it's not enough, because we know that not all patients respond well, and there's also the issue of the patient progression on the treatment, in which case we need to have other strategies. Now, there's another drug. This is a study which was presented by Dr. Pant, the Horizon BTC-01, which was a phase 2b study of zanidatamab in previously treated, patients who have HER2 amplified biliary cancers. I just want to take a minute here just to go over the distribution of the HER2 amplification. In the biliary system, we're looking at biliary system like we're now happening in the colon. You have right and left. Biliary has also multiple stages. So the gallbladder, there's a higher expression of the HER2, whereas in the intrahepatic is really very low. Remember, in the intrahepatic, we see more of the IDH1 and the FGFR. So this bispecific HER2 targeting antibody was given every 2 weeks. And the conclusion from this study was that you will see a rapid and durable response, and it was with manageable toxicities. And if you look at those graphs here, they really prove the point that I'm trying to make. If we move next to trastuzumab and deruxtecan, And this was a study, Destiny Pan Tumor 02, which was across multiple solid tumors that were HER2 positive. And here you would see that there is a response in across the tumor types. Pancreatic is really the least, but again, they had only the sample size is not enough to make any conclusions. But you can see that there was response rate across multiple tumor types. And what I really want to discuss here is the toxicity in terms of the toxicity of interest, grade, the lung and cardiac toxicities. The ILD pneumonitis is at any grade was 7.5 and percent. On only one patient had grade 5, but most were in grade 1 or 2. Left ventricular ejection reduction or left ventricular dysfunction, again, was really very infrequent and only in the earlier grades of the disease. So the conclusions were that it has activity across cancers and higher response rates again in patients who have IHC3+, but we didn't see this huge difference that we saw earlier in the previous study I showed you. In IHC3+, however, you have a better duration of response than IHC2+. Finally, talking about NAPOLI-3, this was a phase 3 trial looking at NALIRIFOX versus gemcitabine and nab-paclitaxel in patients with metastatic pancreatic cancer. This study was a phase 3 trial that was initially presented in ASCO GI and showed the superiority of the triplet over the doublet with manageable toxicity for a triplet. And again, if you look at across all the subgroups, it was in favor of using the triplet of the three drugs. One thing I want to really draw your attention to is are the doses used. If you look at the liposomal irinotecan, it was 50. The 5-FU is the same. There's no bolus 5-FU, and the oxaliplatin is down from 85 to 60 milligram per meter squared. In my opinion, this study establishes the role of the NALIRIFOX in the frontline treatment, and also it's a proof of concept that the triplet is better than doublet in patients who have favorable performance status in this disease, which really helps us to understand why we're also using triplets, not only in the frontline treatment of patients with pancreatic cancer because we think it's better than doublet, but also its utility in two other situations. One would be in the neoadjuvant setting, for example, and the other one would be if you have older patients where we always had difficulty with FOLFIRINOX, it may be that we have a bit of a better way of treating them with a triplet when we use the NALIRIFOX.